Hello everyone, a very good evening everyone. So these particular sessions are very much useful for your upcoming NEET SS exam. So I have selected some of the very important topics which will be very much useful and which are very high yielding and scoring topics for your NEET SS exam. And so today I will be discussing the topic that is shock and the hemodynamics, in which I'll be discussing about the various types of shock, that is sepsis, cardiogenic shock, hypovolemic shock, and as well as the neurogenic shock as well. So after having discussing about these various types of shock, I will also discuss some of the multiple choice questions on the same topic as well. So anywhere you get the doubt, you can just text me on the chat box. I'll be very happy to answer your questions. Right. So having said this, let us start with this topic. So I have made this entire topic in a tabular column. And once the session is over, the PowerPoint or the PDF will be sent to you with annotations. Okay. Right. So, right. The first thing is the basic definition of the shock. So, what do you understand by this shock as such? It is one of the life-threatening dysfunction, or where there is an organ dysfunction that is mainly due to imbalance between the cellular organ supply and as well as the demand. So supply of the oxygen will be less, but the demand will be more. And what exactly will be the basic consequence of the shock? The basic consequence of the shock is that the individual can progress from reversible to irreversible phase that will lead to multi-organ dysfunction. Okay, so these patients, they will have multi-system organ failure, right? So initially this multi-system organ failure will be in a reversible state, and this reversible state can progress to the irreversible state. That is what will happen in a patient with a shock. Now, if you see the pathophysiology of the shock, so you take any type of shock, what will be the basic problem? There is impaired oxygen delivery or there is impaired oxygen utilization. And not only there is impaired oxygen delivery or the impaired oxygen utilization, in these patients, there will also be the initiation of the anaerobic metabolism. And because of the initiation of anaerobic metabolism, there will be excessive accumulation of lactic acid. That is another important problem. And the next important is there will be decreased ATP synthesis. Why? Because there is decreased oxygen supply to the tissues. And there will also be cellular dysfunction. Right? There will also be cellular dysfunction. So this will be the pathophysiology of the shock. Now, what are the important determinants of the oxygen delivery? So if you see the important determinants of the oxygen delivery, the important determinants include the following. What is that? That is the determinants of the oxygen delivery. If you see, that is the cardiac output and as well as the arterial oxygen content. These are the two important determinants of the oxygen delivery. Cardiac output. What is this cardiac output dependent on? This cardiac output, it is dependent on the heart rate multiplied by the stroke volume. So any factor which is affecting the heart rate or any factor which is affecting the stroke volume, that will affect the determinants of the oxygen delivery. And the other factors which will determine this oxygen delivery is the arterial oxygen content. What is it again dependent on? This is again dependent on the factors like the systemic vascular resistance, that is the resistance given by the vessel, and it is also dependent on the contractility of the heart, that is the stroke volume, and it also depends on the hemoglobin, and it also depends on the oxygen saturation. So these are the determinants of the oxygen delivery. Two things: cardiac output. Number two, the arterial oxygen content. These are the two important determinants of the oxygen delivery. Now, what are the various types of shock? The various types of shocks, they include the distributive shock, cardiogenic shock, hypovolemic shock, and then the obstructive shock. These are the four important types of the shock. And I'll be discussing about these shocks in detail subsequently. And there are totally 3 stages in shock. What are these 3 stages in shock? That includes compensated, decompensated, and as well as irreversible. I'll also be discussing what is compensated, what is decompensated, and what is irreversible. Right. Now, first, let me just discuss the types of the shock, individual types of the shock. So what are the types of shock we have discussed? That is the distributive shock, then cardiogenic shock, then hypovolemic shock, then obstructive shock. So first, let me take up the discussion of the distributive shock. What exactly happens in these patients with the distributive shock? Now, in patients with the distributive shock, very important, what is the etiology for the distributive shock? The very important etiology for the distributive shock that includes sepsis. Right? Sepsis is one of the very important etiology. What this sepsis will do? This sepsis will release the inflammatory cytokines. And the another important etiology for the distributive shock is the anaphylaxis. Now, what is being released in anaphylaxis? In anaphylaxis, there will be release of the histamine. And third important cause for the distributive shock will be a form of a neurogenic shock. Right? A form of neurogenic shock. Right. Now, in neurogenic shock, what will be the problem? In neurogenic shock, there will be decrease in sympathetic tone. These are the causes for the distributive shock. Right? Number one, sepsis, where there will be release of the inflammatory cytokine. Anaphylaxis, where there will be release of the histamine. Neurogenic shock, where there is loss of sympathetic tone. Now, because of all these, what will happen is there will be reduced systemic vascular resistance. That is the main problem. Right? The main problem is there will be reduced systemic vascular resistance. And because of reduced systemic vascular resistance, that will lead to vasodilatation and as well as the hypotension. Right. Now, once there is reduction in the systemic vascular resistance, right, and once there is hypotension, what is a compensatory event that will be happening in the distributive shock? The compensatory event is there will be increase in the cardiac output initially. In early stages, there will be increase in the cardiac output. So the point to remember here is in patients with the distributive shock, there is decrease in systemic vascular resistance. Next, coming to the cardiogenic shock. What are the causes for cardiogenic shock? That includes myocardial infarction. Number two, myocarditis is the cause for the cardiogenic shock. And number three, the arrhythmias. Right? Number three, arrhythmias. These are the causes for the cardiogenic shock. What happens in cardiogenic shock? In cardiogenic shock, there will be decrease in cardiac output. Why? Because of impairment of the cardiac function due to MI or myocarditis or arrhythmia. Now, as a compensation, what will happen to systemic vascular resistance in patients with the cardiogenic shock? Please remember, in patients with cardiogenic shock, there will be increase in systemic vascular resistance as a compensatory mechanism. In distributive shock, because of cytokine release or histamine release or because of loss of sympathetic tone, systemic vascular resistance decreases in case of distributive shock. This is about distributive and cardiogenic shock. Then, what is the third type of the shock? The third type of shock is the hypovolemic. Next, we have obstructive and then mixed shock. Okay, coming to the hypovolemic shock. In case of the hypovolemic shock, what happens is there will be significant reduction in the intravascular volume. What could be the reason for the hypovolemic shock? What are the etiologies? the etiologies for the hypovolemic shock, that includes number one, the hemorrhage, right? Number two, severe dehydration, right? Severe dehydration. And the other etiologies for the hypovolemic shock, it includes burns, then diarrhea is another cause for the hypovolemic shock, and even the excessive vomiting. So these are the causes for the hypovolemic shock. So whenever there is hypovolemic shock, there is reduction in the intravascular volume. And this will lead to decrease in preload and as well as decrease in cardiac output. Now, there is decreased preload, there is decreased cardiac output. So what is the compensation? In order to improve the blood pressure, the systemic vascular resistance increases, right? So in distributive shock, systemic vascular resistance reduced. Cardiogenic shock, systemic vascular resistance increased. Hypovolemic shock, systemic vascular resistance is increased, right? Now, coming to the obstructive shock. Now, what are the causes for the obstructive shock? The causes for the obstructive shock, it includes, number one, pulmonary embolism. Number two, cardiac tamponade, right? Number two, cardiac tamponade. Number three, pneumothorax, and that too, it is tension pneumothorax, and then restrictive pericarditis, right? Restrictive pericarditis. These are the causes for the obstructive shock. So in obstructive shock, like what exactly is the problem? The problem is there will be reduced cardiac output. Why? That is due to external obstruction of the cardiac filling or the outflow. Now, where is that? You have the external obstruction of the cardiac filling. You have that in cases of the cardiac tamponade. And where is that? You have an external obstruction to the outflow. That is in patients with the pulmonary embolism. So in patients with pneumothorax or in patients with your cardiac tamponade, there is external obstruction of the cardiac filling. Whereas in patients with the pulmonary embolism, there is obstruction to the outflow. Now, in patients with the obstructive shock, what is that we are discussing? The cardiac output is reduced. Now, as the cardiac output is reduced, like as a compensatory mechanism, what will happen to the systemic vascular resistance? There will be increase in the systemic vascular resistance. So until now, whatever we have discussed, only in distributive shock, we have discussed that systemic vascular resistance is reduced. Whereas in all other forms, we have discussed that the systemic vascular resistance is increased. Now, what is the last type of shock? That is mixed shock. What is that here? There is a combination. It's a combination of distributive, cardiogenic, hypovolemic, or the obstructive mechanisms which occur simultaneously, right? Which occur simultaneously. So this is what is your mixed shock. So these are all the various types of shocks, right? Number one, the distributive shock. Number two, cardiogenic shock. Number three, hypovolemic shock. Number four, obstructive shock. Number five, mixed shock. Now, having said this, let me discuss the stages of shock. There are totally three stages in the shock, right? There are totally three stages. What are these three stages? Number one, the compensated. Number two, decompensated. Number three, irreversible shock. So these three are the stages of the shock. Now, you take compensated. Compensated is a pre-shock, right? Compensated is a pre-shock. In compensated, the symptoms are very minimal and there is very mild organ dysfunction, right? Minimal symptoms and there is mild organ dysfunction. And in patients with compensated shock, there is physiological compensation. And what is that abnormalities that you will notice in a compensated shock? In a compensated shock, there will be decreased oxygen supply to the tissues. Thereby, what will happen to the lactate levels? There will be increase in the lactate levels because of the anaerobic metabolism. And there is decreased renal perfusion. That is the reason why there will be increase in serum creatinine because of pre-renal type of kidney injury. And at the same time, there will be myocardial injury in case of cardiogenic shock. The troponin levels will be elevated. That is what you will notice in case of compensated shock. Whereas you take in case of the decompensated shock, In case of decompensated shock, there is clear signs of the organ dysfunction. Right? There is clear signs of the organ dysfunction. Right? And here in decompensated shock, when you do a prompt intervention, right? When you do a prompt intervention, the disorder is reversible. So it is reversible with prompt intervention. That is in case of the decompensated shock. Whereas in case of the irreversible shock, there is a permanent organ dysfunction. So these patients, they progress to multi-system organ failure. Right? They progress to multi-system organ failure. So here these patients, they are irreversible, right? They are irreversible even with treatment. That is what is your compensated, decompensated, and irreversible. In compensated, please remember the symptoms are very minimal symptoms, mild organ dysfunction. In decompensated, it is reversible with prompt intervention. And in irreversible, the individual will progress to multi-system organ failure, and it is irreversible even with treatment. That is what is your irreversible shock, right? Now, let me take up the details of the individual types of shock. So what did I tell you? Like you have distributive shock, then cardiogenic shock, hypovolemic shock, obstructive shock, and as well as mixed shock. Now, let me discuss about the individual types of shock. You take distributive shock. What are the etiologies that we have discussed? Sepsis, where there will be release of cytokines. Anaphylaxis, where there will be release of histamines, right? And neurogenic shock, where there will be inhibition of the sympathetic tone, and even the adrenal insufficiency comes under the distributive shock. Now, in distributive shock, what is that we have discussed about the systemic vascular resistance? There will be decrease in the systemic vascular resistance. And at the same time, there will be compensatory increase in the cardiac output. There is compensatory increase in the cardiac output. So if you take the hemodynamic profile in distributive shock, hemodynamic profile is the one which is largely tested for your exams. So we have discussed that systemic vascular resistance is reduced. There is compensatory increase in the cardiac output, right? Because systemic vascular resistance is reduced. What actually is systemic vascular resistance? It is the afterload which is given over the left ventricle. Once your afterload on the left ventricle is reduced by decreased systemic vascular resistance, what will happen to cardiac output? Cardiac output obviously increases. And there will be decrease in the central venous pressure because the preload is being reduced. And there will also be decrease in pulmonary capillary wedge pressure. There will also be reduction in the pulmonary capillary wedge pressure. Okay. What could be the reason for decrease in pulmonary capillary wedge pressure? That is because of decrease in your systemic vascular resistance. There is vasodilatation basically. So that is the reason why there will be decrease in pulmonary capillary wedge pressure here. So this is about the story in case of distributive shock. Now, what will be the clinical features in patients with the distributive shock? Do they have cold extremities? No. In distributive shock, please remember the extremities will be warm extremities. And what is that we are discussing? Cardiac output is reduced and systemic vascular resistance is reduced. I'm sorry, cardiac output is increased and systemic vascular resistance is reduced. So thereby what will happen to pulse pressure? Cardiac output will determine systolic blood pressure. Systemic vascular resistance will determine diastolic blood pressure. So thereby there will be wide pulse pressure. Thereby there will be wide pulse pressure, right? And there is a high scope that there would be fever as well. Okay, because the individual is having sepsis as one of the cause. So fever will be there in these individuals. Okay. So in distributive shock, please remember the individual will not have cold extremities. The extremities will be warm extremities. Then coming to the cardiogenic shock. In cardiogenic shock, there will be reduction in the cardiac output. What could be the reason? Due to impairment of the cardiac function. Now, what are the causes for cardiogenic shock? That includes myocardial infarction, that includes arrhythmias, that includes myocarditis, and as well as the valve dysfunction. So these are all the etiologies for cardiogenic shock, which already I have said you during the pathophysiology also. Now, the very important part of the discussion is the hemodynamic profile. So if you take the hemodynamic profile in case of the cardiogenic shock, there will be decrease in the cardiac output, and there will be increase in systemic vascular resistance as a compensatory phenomena. There is a backflow of blood because of left ventricular failure. There will be increase in the pulmonary capillary wedge pressure. And at the same time, your right-sided heart failure is also one of the etiology for cardiogenic shock, and thereby your central venous pressure is elevated. Now, you see these parameters, whatever we have discussed in the distributive shock are exactly opposite what we see in the cardiogenic shock. In distributive shock, we have discussed systemic vascular resistance is reduced. In cardiogenic shock, systemic vascular resistance is being increased. And the remaining all parameters you check, everything is opposite. So distributive shock and cardiogenic shock, the hemodynamic profile is completely opposite. And even the clinical presentation also, if you observe, in distributive shock, what did I tell you? They'll have warm extremities and wide pulse pressure. Whereas in cardiogenic shock, these patients, they will have cool, clammy skin, and there is delayed refill because the cardiac output is reduced. There will be edema, both pulmonary edema will be there, because of which the individual will have dyspnea, and there will also have the pedal edema as well. And there will be elevated JVP because of the right heart failure. Okay, so this will be the picture in case of the cardiogenic shock. Now, so having said about the distributive shock and the cardiogenic shock, now let me discuss about the hypovolemic shock. In hypovolemic shock, there will be reduced cardiac output. Why there is reduced cardiac output? That is due to decreased intravascular volume. Okay, so as there is decreased intravascular volume, what will happen to preload? The preload will be reduced. As the preload is reduced, the cardiac output will be reduced. So what are all the various etiologies for hypovolemic shock? That is hemorrhage, and that hemorrhage could be secondary to trauma or gastrointestinal blood loss, or it might be an internal bleeding, right? Or it could be because of the fluid loss. And the fluid loss, it could be because of the burns, then vomiting, or even it could be due to diarrhea also. Now, I said you hemodynamic profile is the one which is being commonly tested in your exams. So here, the cardiac output is reduced because the preload to the heart is reduced. So compensatory to that, systemic vascular resistance is increased. And there will be decrease in central venous pressure, right? And there will be decrease in the pulmonary capillary wedge pressure. Why? Why? Because the volume is reduced in our body. That is the reason why your pulmonary capillary wedge pressure and even central venous pressure is also reduced. And accordingly, cardiac output is also reduced. Whereas the systemic vascular resistance is increased. So the only parameter which is increased in hypovolemic shock is increase in systemic vascular resistance. That's all. And in hypovolemic shock, as the cardiac output is reduced, how will be the extremities? Cold extremities. There will be delayed refill, weak pulses, and hypotension. Right? So this particular picture, if you see in case of the hypovolemic shock, the only difference between hypovolemic shock and cardiogenic shock presentation is in cardiogenic shock, the individual had edema, the individual had elevated JVP. Whereas in hypovolemic shock, there will be hypotension and there will be weak pulses, and edema will not be there in case of the hypovolemic shock. That is the difference in the presentation. Then coming to the obstructive shock. In obstructive shock also, there will be reduced cardiac output. And what could be the reason? Due to obstruction of the blood flow, right? Due to obstruction to the blood flow. Now, what all could be the reasons for obstruction to the blood flow? That is in pulmonary embolism, right? There will be reduced outflow to the pulmonary artery. So thereby preload onto the left ventricle is reduced. Next, tension pneumothorax and as well as cardiac tamponade. There will be impairment of the cardiac filling, and same is your restrictive pericarditis also. So in tension pneumothorax, cardiac tamponade, restrictive pericarditis, there is impairment of the cardiac filling. That is the reason why there will be reduced cardiac output. So if you take the hemodynamic profile in case of obstructive shock, there will be decreased cardiac output. So whenever there is decrease in cardiac output, please remember the compensatory phenomena is there will be increase in the systemic vascular resistance, right? And what about your central venous pressure and as well as pulmonary capillary wedge pressure? This will be variable, right? This will be variable depending upon the underlying cause. What will be the presentation of the obstructive shock? Dyspnea. mainly in pulmonary embolism, tension pneumothorax, cardiac tamponade, they present with dyspnea, right? And you take chest pain. In case of restrictive pericarditis, they present with chest pain. And in patients with cardiac tamponade, there will be elevated JVP. And even in pulmonary embolism, there will be elevated JVP. And in cardiac tamponade, you will have the pulsus paradoxus. Right? Cardiac tamponade, you will have pulsus paradoxus. Okay. So now, yeah. Can anyone tell me what is the definition of the pulsus paradoxus? Anyone of you? What is the definition of the pulsus paradoxus? How much will be the fall in systolic blood pressure upon inspiration? Right. So in case of the pulsus paradoxus, the fall in systolic blood pressure will be more than 10 millimeters of mercury during inspiration. That is what is your pulsus paradoxus. In a normal person, the systolic blood pressure falls less than 10 millimeters of mercury, but in pulsus paradoxus, the fall in systolic blood pressure will be more than 10 millimeters of mercury, right? Okay. That was about the obstructive shock. Then finally, coming to the mixed shock. Mixed shock, it is always the combination, right? It is the combination of multiple shock types that is called mixed shock. So here you will have sepsis, and the sepsis causing myocardial depression, that will be like cardiogenic. And next is the severe pancreatitis would be the causes for the mixed shock. And here the hemodynamic parameters, it is always variable, right? It is always variable. And what will happen to the cardiac output? There will be decrease in the cardiac output, right? And the clinical features, it is always mixed. The clinical features always will be mixed. Okay. So this will be the detailed discussion related to the various types of shock: hypovolemic, obstructive, mixed, and next distributive, and as well as the cardiogenic shock. And you need to know the workup for the individual types of shock. That is diagnostic tests for the individual types of shock. So you take this distributive shock. What are the causes for distributive shock that we have discussed? Sepsis, anaphylaxis, or neurogenic shock. So you need to do a complete blood picture. What is the purpose of doing complete blood picture? There will be elevated WBC, mainly if it is secondary to sepsis, right? There will be left shift. And you need to do blood culture where it will be positive if it is sepsis. And what will happen to the lactate levels? Lactate levels are being elevated because there is hypoxia and causing anaerobic metabolism. That is the reason why the lactate levels are being elevated. And ABG shows that there will be metabolic acidosis. And this metabolic acidosis, it might be due to increase in the lactate levels or due to decreased ammonia excretion whenever the individual goes into a state of kidney injury. And prolactin levels are elevated in case of the distributive shock. And what does the chest X-ray show? For example, if the cause for sepsis, if it is pneumonia, you will have either consolidated picture, or there can be patchy consolidation if it is bronchopneumonia, or it can be an interstitial pattern if it is atypical pneumonia, right? Or the chest X-ray will also show you that there is presence of the infiltrates. Okay, so this will be in distributive shock. And what will happen to your IgE levels? The IgE levels or the skin test, they are very much useful for the diagnosis of the anaphylaxis, right? And what is the purpose of doing MRI or CT spine? That is mainly to diagnose the neurogenic shock, right? To where spinal injury, right? Where spinal injury can lead to the neurogenic shock. Okay, so that is the purpose of doing, right? That is the purpose of doing the MRI or CT of the spine. Next. Now, in cardiogenic shock, what are the investigations that, or what is the workup that you need to do? One is very important, ECG, that is mainly to rule out the ischemia, or is it only ischemia, or is there development of the infarction? We will be able to make out on the ECG. And next is to check for if there is any development of the arrhythmias, right? To check for is there any development of the arrhythmias. And cardiac enzymes, they're usually elevated. What are those cardiac enzymes elevated? That is CKMB, troponin, they are being elevated. Now you take the 2D echo. So 2D echo, it will show that there will be reduced ventricular function, right? So either it could be heart failure with reduced ejection fraction, or it could be heart failure with preserved ejection fraction, either HFpEF or HFrEF. And there will be, there can also be valvular dysfunction, like mainly aortic stenosis and all. These all will lead to the obstruction, or valvular abnormalities will also lead to the development of the cardiogenic shock. Okay. Next, chest X-ray. Chest X-ray, this will show you that there is pulmonary edema, right? There will be pulmonary edema, or there can be cardiomegaly also, right? There can be cardiomegaly also, right? And BNP levels are elevated mainly if the heart failure is causing the cardiogenic shock. And why is that you need to do coronary angiogram in a patient with a cardiogenic shock? That is mainly to look for if there is any arterial blockade, right? If there is any presence of the arterial blockade, you need to do the coronary angiography. So this is about the workup that we do in case of the cardiogenic shock. Now, followed by that, what is a workup that you will do in patients with the suspected cases of the hypovolemic shock? You need to do a complete blood picture, right? So complete blood picture, it may show you that there is low hemoglobin. What could be the reason for the low hemoglobin in a hypovolemic shock? That could be because of the hemorrhage, right? And you need to do a coagulation test. The coagulation test, that is PT and APTT, may be abnormal. What could be the reason? Because of the hypovolemic shock, there may be liver injury also. And liver injury is the one that will lead to decreased synthesis of the coagulation factors. Thereby, PT, APTT will be abnormal. And even electrolytes can be abnormal, right? What will be that electrolyte abnormality? Usually they can have hyperkalemia or hyperphosphatemia. What could be the reason? Because once there is a kidney injury, the potassium is not excreted out. So that can result in the hyperkalemia. And lactate levels, they are elevated. And ABG will show that there is metabolic acidosis, right? ABG will show that there is metabolic acidosis. And USG abdomen or CT abdomen has to be done to look for the internal bleeding, because one of the cause for the hypovolemic shock is the internal bleeding. So you need to do the CT or MRI of the abdomen to rule out the internal bleeding. And endoscopy should be done mainly to rule out gastrointestinal bleeding, because gastrointestinal bleeding is one of the cause for the hypovolemic shock. So these are the investigations that you need to do in case of hypovolemic shock. Then followed by that, the workup that we do in case of the obstructive shock. In case of obstructive shock, you need to do a chest X-ray. Why? To rule out the pneumothorax. And in pneumothorax, what will be the chest X-ray finding? The chest X-ray finding in pneumothorax will be hyperlucent lung fields, collapsed lung. There will be absence of bronchovascular markings and shift of the mediastinum to the opposite side. That is what you will notice in case of the pneumothorax. And you also need to check if there is any mediastinal widening, right? Mediastinal widening. Okay. Mediastinal widening, where can you observe this? You can observe this in your massive pericardial effusion or cardiac tamponade, which will be causing the obstructive shock. And next is CT angiogram. The purpose of doing CT angiogram is to rule out pulmonary embolism. That is one of the cause for the obstructive shock. And echocardiography should be done to look for the cardiac tamponade, where you will notice that there is diastolic collapse of the right ventricle in case of the cardiac tamponade. And ECG you have to do in order to look for if there is any presence of tachycardia, because in pulmonary embolism, the most common ECG finding will be tachycardia. Or you have to check for if there is any presence of low voltage complexes, because in patients with pneumothorax or in patients with pericardial effusion, or there will be low voltage complexes. And what is the criteria for low voltage complexes? The amplitude of the QRS complex should be less than 5 mm in the limb leads, and amplitude of the QRS complexes in the chest lead should be less than 10 mm. That is what is the criteria for low voltage complexes. And you need to do a Doppler ultrasonography mainly to rule out deep vein thrombosis, which can be the source for pulmonary embolism causing the obstructive shock. And ABG has to be done. The ABG has to be done to look for if there is any presence of the hypoxemia or respiratory alkalosis. Now, what could be the reason for respiratory alkalosis? Because in patients with pulmonary embolism, there is increase in respiratory rate that will cause carbon dioxide washout, resulting in respiratory alkalosis. So this is the workup that you'll be doing in patients with the obstructive shock. So I have discussed about the workup about the individual types of shock. Now we'll move on to the treatment for the specific types of shock. You take in distributive shock. What is that? We have discussed the etiology as the sepsis, or like the anaphylactic shock or neurogenic shock. So the treatment that you need to give is the IV fluids like normal saline. And if only with IV fluids, if the individual does not respond, then vasopressors have to be administered. And these vasopressors include norepinephrine, epinephrine, or the vasopressin. And for sepsis, you need to give broad spectrum antibiotics until you get the result of the culture and sensitivity. And for anaphylaxis, the drug which you need to give very importantly is the epinephrine. And adrenal insufficiency is one of the cause for distributive shock. So for adrenal insufficiency, you need to give steroids. And which particular steroid we give mainly? It is hydrocortisone. This is the treatment for distributive shock. Then you see the treatment for cardiogenic shock. In cardiogenic shock, you need to give inotropic agents. And what is this important inotropic agent that we give in case of the cardiogenic shock is we give dobutamine, right? So we need to give dobutamine, right? And also you need to address whatever is the underlying cardiac cause. So you need to treat whatever is the underlying cause, either myocardial infarction, or it could be arrhythmia, or it could be ischemia also. So the addressing the underlying cause, it includes revascularization. If it is an underlying coronary artery disease, right? Or you need to do an interventional surgery, right? Depending upon, okay, valve repair is another important thing, right? Or you need to treat the underlying arrhythmia. That is if it is cardiogenic shock. Then you take a hypovolemic shock. In hypovolemic shock, the mainstay of treatment will be the fluid resuscitation. The mainstay of treatment will be fluid resuscitation. And what is that we give initially? Initially, we give crystalloids, right? Initially, we need to give the crystalloids, right? And if the individual is having hemorrhage, then these patients will be requiring the blood products. These patients will be requiring the blood products for hemorrhage, right? Or these patients may require surgery also if there is any rupture of the vessel causing the hemorrhage, right? Or you need to do endoscopy after stabilization to look for gastrointestinal bleed. And if there is any gastrointestinal bleed secondary to esophageal varices, then what is that you need to do? Esophageal variceal ligation or banding should be done, right? Or endoscopic sclerotherapy should be given. This is the treatment for hypovolemic shock. Now, coming to the obstructive shock. Now, obstructive shock, for example, one of the etiology for the obstructive shock is tension pneumothorax. So what is that you need to do tension pneumothorax? You need to do emergency decompression. That emergency decompression is that you need to take a wide bore needle and puncture the second intercostal space in the midclavicular line. And followed by that, you need to place an ICD in the fifth intercostal space in the mid-axillary line. Okay, that is decompression should be done. Now, if pulmonary embolism is the cause for the obstructive shock, then what is that you need to do is thrombolytic therapy has to be given, right? Or embolectomy has to be considered. That is, surgery has to be considered. Now, if cardiac tamponade is the cause for obstructive shock, then what is that you need to do? You need to plan for pericardiocentesis, right? You need to plan for the pericardiocentesis, right? And if there is aortic dissection causing obstructive shock, then immediately you need to plan for the surgical intervention, right? Surgical intervention. Okay. So this is about the treatment. This is about the treatment in case of the obstructive shock, depending upon the underlying cause, right? So this is about the various types of shocks, right? And I've said everything about the shock. I said you pathophysiology of the individual types of shock, right? Second, I have said you about the stages of shock, right? Compensated, decompensated, and irreversible. Then I have said you the hemodynamics in various types of shock. Then I have said clinical features on various types of shock. Then I have discussed the investigations, what you need to do in various types of shock, and what are the various treatment options in various types of shock. Now, we have last 10 minutes. We'll try to discuss some questions. Right, we'll discuss some questions. right? I want everyone active participation in answering these questions. Please answer this. We have a 65-year-old male with diabetes and hypertension, and he presents with fever, tachycardia, and hypotension. His skin is warm and flushed. What is the most likely type of shock in this patient? Hypovolemic shock, cardiogenic shock, septic shock, the obstructive shock. Yes, anyone want to make an attempt of this? Right, very good, Mahata. So the answer is the septic shock. So in septic shock, I said the extremities will be warm and as well as flushed. And what is the hemodynamics that I have discussed in case of the septic shock? Septic shock is nothing but it is a type of distributive shock. In case of septic shock, the hemodynamics will be decrease in systemic vascular resistance. And what could be the reason for decrease in systemic vascular resistance? Because of release of cytokines in sepsis. And there will be increase in the cardiac output. And there will be decrease in the central venous pressure. And there will be decrease in the pulmonary capillary wedge pressure. Okay, so that is what is the picture that you will observe in case of the septic shock, right? Now, we'll move on to the next question. And another important pointer to tell it is septic shock, the fever. Fever is classically observed in case of the septic shock. Now, next question. So, a patient presents after a motor vehicle accident with profuse bleeding. He's pale, diaphoretic, and has a weak pulse. What is the most likely type of shock here? Yes, what is the most likely type of shock? Distributive, hypovolemic, cardiogenic, neurogenic. So here, right, good. So it is the hypovolemic shock. So what is the, here it is very clearly given, motor vehicle accident presented with profuse bleeding, right? And is pale, diaphoretic, and as well as weak pulse. And in hypovolemic shock, what is the hemodynamic profile? In hypovolemic shock, the hemodynamic profile will be, there will be decrease in cardiac output, there will be increase in systemic vascular resistance, there will be decrease in central venous pressure, and there will be decrease in pulmonary capillary wedge pressure. That is what you will observe in case of the hypovolemic shock. And the extremities will be cool, and there will be delayed refill, weak pulses, and hypotension will be there in case of the hypovolemic shock, right? Next question. Okay. So we have a 58-year-old male presents with chest pain, diaphoresis, hypotension, and pulmonary rales. ECG shows ST segment elevation in lead 2-3 AVF. What type of shock is most likely present in this patient? Yes, anyone? Yeah, so this will be the cardiogenic shock. This will be the cardiogenic shock. So in cardiogenic shock, what is that we have discussed? There will be reduced cardiac output due to impaired cardiac function. So the individual is having ST segment elevation in 2-3 AVF. What does it suggest you of? It is suggest you of the inferior wall MI. And inferior wall MI, there will be cardiogenic shock. So what will be the hemodynamic parameters in cardiogenic shock? There will be decrease in cardiac output. There will be increase in systemic vascular resistance, right? And there will be increase in pulmonary capillary wedge pressure. And there will be increase in the central venous pressure. So this is what you'll observe in case of the cardiogenic shock, right? Next question. Okay. So here, a patient with cervical spine injury, cervical spinal cord injury, presents with hypotension, bradycardia, and warm extremities. What type of shock is this suspected? So warm extremities, immediately what is that you need to think of here? Right. So it is the neurogenic shock. But neurogenic shock is what? It is a type of distributive shock. right? It is a type of the distributive shock. So in case of the neurogenic shock, what is that you will observe is there will be decrease in systemic vascular resistance. There is increase in cardiac output. There will be decrease in central venous pressure, and there will be decrease in pulmonary capillary wedge pressure. That is what you will observe in case of the neurogenic shock. Neurogenic shock, it's a type of the distributive shock, right? Next. Okay. So we have a 40-year-old woman presented with sudden onset dyspnea, chest pain, and hypotension. ECG shows sinus tachycardia with an S1Q3T3 pattern. What type of shock is this patient having? Right. So now pulmonary embolism is the correct answer, but answer is not A. Answer is not A. Right. Very good, Nirmalesh Mahata. So that is the obstructive shock. Because in pulmonary embolism, it is an obstructive shock. And what will be the hemodynamic profile in case of the obstructive shock? There will be decrease in cardiac output. There will be increase in systemic vascular resistance, right? Whereas central venous pressure and as well as pulmonary capillary wedge pressure, they are variable. They are variable. Okay. So what are the various causes for obstructive shock? We have discussed pulmonary embolism is one important. Then we have tension pneumothorax, cardiac tamponade, and restrictive pericarditis. Okay. So the answer here is the obstructive shock. It is not the cardiogenic shock, right? Now, so what is that you're making you to answer it as pulmonary embolism? That is S1Q3T3 pattern, which is observed in cases of massive pulmonary embolism. Yeah. Next one. So a patient with chronic steroid use presents with severe hypotension, fatigue, and hyponatremia. What is the suspected cause of this shock? Right, good. So, right. So the answer is the adrenal insufficiency, and it is a form of distributive shock. It's a form of the distributive shock, right? The answer is C, adrenal insufficiency, right? So what could have happened in this patient? A patient with chronic steroid use, present with severe hypotension, fatigue, and as well as the hyponatremia. So this individual might have developed the iatrogenic Cushing's, right? Or the other thing is he might have suddenly stopped the steroid therapy. Once he suddenly stops the steroid therapy, what can happen or what will happen? There will be adrenocortical insufficiency, and that will result in the that is what is your adrenal insufficiency, and your adrenal insufficiency is a form of distributive shock. And what is the treatment that you need to give in these patients? The treatment again you need to give is steroid therapy. Right? The reason for the adrenal insufficiency is sudden stoppage of the drug. Okay. Next question. A 35-year-old man was stung by a bee and develops hypotension, bronchospasm, and angioedema. What is the first line treatment in this patient? What is the first line treatment in this patient? Right. So that is, what type of shock is this? It is an anaphylactic shock. Right? It is an anaphylactic shock. So in case of the anaphylactic shock, the drug of choice will be the epinephrine. The drug of choice will be epinephrine. Okay. So this particular epinephrine or anaphylactic shock, it is a form of distributive shock. Right? It is a form of distributive shock. Now in distributive shock, what is the parameters that we have discussed? There will be decrease in systemic vascular resistance. There will be increase in the cardiac output. There will be decrease in central venous pressure, right? And there will also be decrease in pulmonary capillary wedge pressure. That is what you'll observe in case of the anaphylactic shock, right? Which is nothing but a form of distributive shock. Next question. Okay. So we have one particular patient. He's in shock and he has a distended neck veins, muffled heart sounds, and pulses paradoxes. What is the likely cause? Yes, what is the likely cause? So the answer here is distended neck veins, muffled heart sounds, and pulses paradoxes. These three, they are the characteristic features of the cardiac tamponade. And remember, your cardiac tamponade, it does not come under your cardiogenic shock. Yeah, the answer is cardiac tamponade. The cardiac tamponade does not come under your cardiogenic shock. The cardiac tamponade, it comes under obstructive shock. Right? It comes under obstructive shock. Okay. So what will be the hemodynamics in obstructive shock we have discussed? There will be decrease in cardiac output. There will be increase in systemic vascular resistance and your central venous pressure, and as well as the pulmonary capillary wedge pressure in case of cardiac tamponade, it is elevated. Right? It is elevated. Okay. So this is about the obstruct. Remember, very, very important point. Cardiogenic shock, there is a high scope that you will land up in answering this as a cardiogenic shock. It is not cardiogenic shock, it is an obstructive shock. Right? Next, where there is obstruction in the filling of the heart in case of the cardiac tamponade. Right? Next question. Okay. So here we have one particular patient. He is in septic shock, remains hypotensive despite the fluid resuscitation. What is the next best step? What is the next best step? Hypotensive despite fluid resuscitation. So what is that you need to start for this patient? So yeah, so the individual is not responding to your IV fluids, right? So what is that you need to start for this patient is you need to start the vasopressors. You need to start the vasopressors. And the individual is in a septic shock. The individual is in a septic shock. And septic shock is what type of shock? It is the distributive shock. Right? It is a distributive shock. Okay. And why there is these patients with septic shock, there will be decrease in systemic vascular resistance. What could be the reason? Because of release of cytokines. Okay. Next question. Last question. A ventilated patient in shock undergoes a passive leg raise test and his cardiac output increases significantly. What does this indicate? A ventilated patient in shock undergoes a passive leg raise test and his cardiac output increases significantly. What does this indicate? Anyone? Yeah, very good, Thomas. So the answer is the individual is having fluid responsiveness. The individual is having fluid response. That means you give fluid, definitely the cardiac output will be increased. So how is it said by? Because once you do a passive leg raise, what will happen? There will be increase in venous return. Once there is increase in venous return, if the cardiac output is increasing, that means the individual will respond to the IV fluids also, because IV fluids also will increase the venous return. So the answer is the fluid responsiveness. Okay. So these are the important questions related to the topic of the shock, right? And this completes the detailed discussion of the shock and as well as hemodynamics. So this PDF will be sent to you, right, on the respective Telegram channel, right? The team will be coordinating with you. So Everything, the entire shock, I have just summarized in the form of tables. Please go through this topic of shock, which is very, very important for your NEET SS exam. So tomorrow, 6 p.m., see you again with the very important topic in the cardiology, right? So thank you very much. See you tomorrow at 6 p.m.